Let me at the outset thank Dr. Justin Paul for having planned this and knitted it so well. We all know cardio-obstetrics is a sub-specialty of cardiology and obstetrics in which we deal with sick patients. And I'm very happy that we will be starting with the first session in which we have Dr. Anita Saxena with us, who is going to tell us about congenital heart disease and pregnancy, how to manage. And I'm sure this masterclass will dwell into other areas where we will discuss journal clubs and case discussions in future. To me, it has been a great learning exercise ever since I joined up with Dr. Justin Paul to learn more about cardio-obstetrics. And there is so much we learn from our obstetrician friends and also from cardiologists from across the country. So thank you and welcome to all of you for this session.
Thank you, sir. I now request Dr. Justin Paul, the course director of the first ever Cardio-Obstetric Masterclass, to give a brief introduction about this masterclass.
Very good evening, one and all. It gives me immense pleasure and privilege to welcome you all for this masterclass. First, at the outset, I would like to thank Almighty God for putting us together in this phenomenal effort of bringing together multiple specialties which are really required to work together hand in hand to manage these women with heart disease. We work with one passion. Any woman with heart disease, however complex it may be, if she is desirous to have a child, if she desires to enjoy motherhood, we should do our level best to support her, to enable her, and empower her to have a safe motherhood. With that passion, we are working together as cardiologists, as obstetricians, as obstetric anesthetists, as maternal and fetal medicine consultants, as pediatricians, as neonatologists, as pediatric cardiologists, and multiple specialties like this, we'll be working together. There is so much of need to improve this field in this nation. As most of us are aware, in developing nations, cardiac disease is the biggest contributor to maternal deaths. Deaths during pregnancy, the single largest contributor is heart disease, as high as 25 to 30% in US and UK. This number is likely to increase in India. Right now, it's less than 5, whereas in some states like in our state, in certain like Kerala, Maharashtra, Tamil Nadu, where the percentage is almost reaching 10% now and 11%. It is likely to increase. We call this obstetric transition. That would mean that there'll be more and more of indirect causes and less of direct causes as the overall health care facilities improve. So we need to team up together and prepare to face this increasing likelihood of increasing proportion of maternal deaths due to heart disease. There is so much of data we do not know. One of the important findings that we have observed is that 2/3 of all mothers who died during pregnancy due to heart disease, the deaths could have been prevented by some changes in the management, as per a maternal death evaluation report from California. If that is the status in California, you can imagine what will be the status in other nations, developing nations. So we need to really work together, support each other, and help each other. So that is the idea that we are working together to learn from you and to teach you and network each and every one of us together. Now, this masterclass, this is the first of its kind in the nation and in the world as well, as I understand. We are starting with the first topic where pregnancies where in congenital heart disease, some of them are contraindicated. Despite telling that the very high exorbitant maternal risk, the desirous to be a mother leads these women with complex heart disease to land with pregnancy, and the risks are high. How are we going to manage these women? This is what we are going to discuss today. But this is going to be a teaser or a trailer kind of thing, because there are so many complex heart diseases which cannot be discussed in this 20-30 minutes of discussion. But we have a great teacher and Professor Dr. Anita Saxena. Dr. Annie will be introducing her and the panelists to all of you. She is going to talk to us and give us an overview of various complex heart diseases where pregnancies are contraindicated. But if these women come to us pregnant, how do we handle them? But however, in the days to come, every month we are going to have one cardio-obstetric program on the first Friday. Please mark your time, 8 to 9 p.m. First Friday of this month, every month, we'll be having this program, and one by one, we'll be dealing with each and every one of these topics in greater details with case presentations. If any of you are interested in joining as a panelist, as a case presenter, as a discussant, feel free to message us or inform us. We'll be happy to include you, to learn from you, because this is going to be a very, very inclusive platform and not at all an exclusive platform, because we need to work together as a big team in this nation to have this masterclass. So once again, I thank God for this privilege and thank God for all these wonderful people who are teamed with us, that we have this privilege of having a cardio-obstetrics masterclass. I'm sure with all your support, we are going to work together and partner with the government's efforts to improve the maternal care for women with heart disease. Thank you very much.
Thank you, sir, for this great initiative. I now invite the panelists for today's session. Dr. Rajesh Vijayvargiya, Professor of Cardiology, PGI Chandigarh. Dr. Rajesh has done more than 200 publications in PubMed Index journals, 15 chapters in reputed medical books, and more than 100 abstract presentations in various national and international scientific meetings. Sir will be joining us shortly. I invite Dr. Pooja Sikka, Professor of Obstetrics and Gynecology, PGI Chandigarh.
Can you share the PPT?
Is the screen visible, sir?
Yeah, visible.
Dr. Pooja has 77 papers published in national and international journals with 572 citations. Her passion in this field is a great encouragement to all of us. Welcome, ma'am. I invite Dr. Sivakumar, Head of the Department of Pediatric Cardiology and Senior Consultant, Institute of Cardiovascular Diseases, Madras Medical Mission, Chennai. Dr. Sivakumar has been awarded Professor Rajendra Tandon Memorial Gold Medal and awarded Cardiological Society of India, Telangana State Chapter, Dr. Reddy Gold Medal and Research Awards by Sri Lankan Heart Association, Colombia. He has 145 papers published in national and international journals. Welcome, sir. I invite Dr. Sunil T. Pandya, Chief Anesthetist, Department of Anesthesia, Perioperative Medicine and Critical Care, AAG Hospitals. Dr. Sunil has 27 publications, authored 22 chapters in obstetric critical care, obstetric anesthesia, labor and analgesia. He is the editor of the World Anesthesia Clinic with 11 Best Paper Awards, national and internationally. Welcome, sir. I now invite the speaker for today, Dr. Anita Saxena, graduated from the prestigious Lady Hardinge Medical College, New Delhi, with outstanding academic excellence. She completed DM Cardiology from Maulana Azad Medical College and joined the prestigious AIIMS New Delhi as a faculty and continued there for over 36 years till her superannuation in November 2021 as Dean Academics, Chief of Cardiothoracic Center and Head of Department of Cardiology. Currently, she holds the position of Vice Chancellor, B.D. Sharma University of Health Sciences, Rohtak, which is a health university under the government of Haryana. Her main contribution has been in the advancement of specialty of pediatric cardiology in India. She serves as an advisor, policy making of a number of organizations such as Children Health Link, World Heart Federation, Medtronic Foundation, RBSK, Government of India. She has represented India at over 65 international fora, presenting her research and experience. Dr. Saxena has published 368 research papers. Her name has appeared in the coveted list of world's top 2% scientists published by the Elsevier and Stanford University on October 4, 2023. She has been regularly training, teaching, and mentoring students of cardiology, pediatrics, and other elite specialties since 1985 and has guided several research projects of doctoral students. So we shall now proceed into the lecture. And before that, I request the audience to post your questions, and we'll be looking forward to answer your queries during the panel discussion. We'll also be having a live Q&A session after the lecture. Over to you, ma'am.
Thank you, Annie, and thanks very much to Dr. Justin Paul for taking this initiative. I have always felt that it is it's a long overdue. When we look at maternal mortality in India, we realize that there is no column for cardiac disease. So we've been talking about eclampsia, we've been talking about other obstetric complications, but we are hardly ever talking about cardiac problems. And I think day in and day out, we've been seeing pregnant women walking in with severe mitral stenosis class 4, taken to the lab, urgent valvotomy done. So I think it's been a long felt need, and I'm very happy that this group has come together, thanks to Dr. Paul and his team for getting us all together and trying to help in improving the care of these women who are presenting to us for the first time during pregnancy with simple and complex heart diseases. So let me just start sharing my screen. I have been asked to speak on congenital heart diseases where pregnancy is contraindicated. So as I said, that many of these women actually present to us when they're already pregnant, and that is where the role of managing these pregnancies, the challenges of managing these pregnancies come up. What I'm going to do is I'm going to just briefly go over the general overview and then talk of some specific diseases. And I'll be very happy if there is discussion at the end of perhaps each disease, if that's acceptable to the panel. So let me just introduce this topic. Congenital heart disease are the most common birth defects, but then we have not been seeing these people surviving to adulthood because of the lot of morbidity and mortality occurring during childhood. But now, with a lot of advances, at least in the Western world, majority of these women or these children are reaching womanhood and are therefore getting pregnant. So postoperative CHD is also becoming an important contributor, at least in the Western world. But what is happening in India, we are still dealing with native or unoperated CHDs, and at times with very complex congenital heart diseases. And of course, Eisenmenger syndrome, which is always very, very challenging to manage. And as I said, that in 2 papers, at least from All India Institute of Medical Sciences, congenital heart disease was diagnosed for the first time in at least 1/4 of the cases presenting during pregnancy. So since this is the first class master class that we're going to have, so I just thought I'll briefly touch upon the cardiovascular adaptations in pregnancy. I'm sure all of us are aware of the increasing blood volume, increasing cardiac output, reducing blood pressure, reducing systemic vascular resistance that happens over a period of time, the maximum effect being in the late 2nd trimester. And then, of course, there are changes at labor also in the form of increased output and further blood pressure increase during uterine contraction. So, and in addition, from cardiac perspective, I would also like to highlight that pregnancy is a hypercoagulable state, and therefore there are increased chances of thromboembolic events, perhaps more so for some of our patients who have underlying congenital heart diseases. So what are the maladaptations that we see because of CHD? The first one, as I said, since there is increase in blood volume and cardiac output, so all the stenotic lesions, be it mitral stenosis, aortic stenosis, are going to get worse because the cardiac output increases and the stenosis therefore gets much worse. Similarly, if you have a case where there is a ventricular dysfunction, again, this is going to be a detrimental factor. The second thing that happens is reduction in blood pressure, reduction in systemic vascular resistance, and there is peripheral vasodilatation, which causes more right to left shunting in patients of Eisenmenger syndrome and in patients of tetralogy of Fallot. So they worsen. And of course, there are changes in the aortic wall, and therefore patients who have abnormalities of aortic wall like Marfan syndrome, coarctation, aortopathy of bicuspid aortic valve are likely to fare worse during pregnancy. So these are some of the conditions listed where pregnancy is contraindicated, and this paper is from 2018 European Heart Journal, where modified World Health Organization class 4 has been listed. Here, all the heart diseases have been divided into 4 classes, rather 5 classes, and class 4 is one where pregnancy is contraindicated. And if you look at the list, then many of these are actually congenital heart disease. For example, pulmonary arterial hypertension of shunts, pulmonary arterial hypertension of Eisenmenger syndrome, and I'm going to talk a little bit about idiopathic pulmonary arterial hypertension also, severely symptomatic aortic stenosis, aortopathies like in Marfan syndrome, coarctation of aorta, and you will notice that cyanotic heart disease are practically missing here. The reason being that majority of cyanotic congenital heart disease would have been repaired by this time, but it is really something that we still see in our practice from time to time. So why pregnancy is contraindicated? Because the event rates are very high. If there is pregnancy, one advises termination. But if mother wants to continue with pregnancy or they come beyond the time of termination, then of course requires a very good care in an expert center. And of course, close follow-up. So before I go further, if there is a lady who is pregnant, who wants to continue pregnancy, what are the questions that we should ask? One is she a known case or diagnosed for the first time during pregnancy? Obviously, those who have been diagnosed for the first time are not going to be as good as those who have already been diagnosed, counseled, treated. What is the underlying diagnosis? Because the way she's going to behave is going to vary depending upon what diagnosis she has, what functional class she is in. And this is very, very important because whichever disease you take, NYHA class is a good prognostic indicator of the risk to the women. Does she have any complications, which could be obstetric complications or which could be cardiac complications like arrhythmias, ventricular dysfunction, thromboembolism, and so on? How far is she in pregnancy? Because we know that changes keep on happening till late second trimester. So if she's really gone on to term and has done well, it is likely that she's going to do well. And is she on any treatment? If not, if yes, what is the kind of treatment is she taking? Whether these drugs are indicated or they are contraindicated, and therefore one needs to modify it. Now, looking at what is the likely diagnosis or what is the underlying diagnosis, I'm going to refer to this paper, which is Rohtak registry, which has a very high number of congenital heart diseases, more than 3,000. And obviously, simple diseases are much more than complex diseases. But if I look at their data, pulmonary hypertension was present in only 5.4% of these more than 3,000 women. But when we look at the morbidity and mortality, then you would, or heart failure, then you would see that Eisenmenger syndrome is really, really very high, much ahead of any other condition. And here the heart failure is seen in almost 48% and mortality is in about 5%. So this is a disease which has very high complication rate, and therefore is something that we may not see very common, but is something that we have to be very careful about. Having said that, in Indian scenario, I think we are going to see far more Eisenmenger syndrome than one would see in the Western countries. Again, the same data where WHO class 4, that means where pregnancy is contraindicated, was present in as many as 4%. But I'm sure if we look at the data from MPEC registry that has been published by Dr. Paul and his group, then it's going to be much more. In fact, I couldn't really isolate CHD patients separately. There were about 352 patients of 346 patients of CHD and over 1,000 in the registry published by Dr. Paul. I believe as many as 19% were in class 4. So almost 1/5 of women are pregnant with the condition where pregnancy is contraindicated. So obviously we get far more of these patients than what is reported from other registries. And I think it will be a very good data if we can combine many of our centers and come up with this number. So how do we manage these mothers who have such severe kind of disease where pregnancy is contraindicated? Yes, of course, counseling, but most of the time they would have come at a time where counseling has role, of course, but there is something that we need to discuss about risk to the mother, risk to the fetus, and not really counseling against pregnancy. Close monitoring, fetal scans and fetal echo at appropriate times. Where do we get her delivered? When should we get her delivered? What should be the mode of delivery? And very importantly, we must not forget the postpartum period where many of these patients actually collapse. Then, of course, establish breastfeeding and also try and tell the mother and the family that at least in future they have to avoid pregnancies or get themselves treated first before going in for the next conception. And this is a concept which has been talked about for a very long time. I think we all are aware of it, but in real terms, in practical terms, I think very few of us are actually following it. And I'm sure these classes and these interaction that we're going to have amongst the group will be something that will encourage formation of these team members. And I would say obstetrician is perhaps the most important team member because she or he is the primary caregiver for this woman. And the woman is going to ask all the questions, all the counseling, everything has to be done by the obstetrician. And of course, there will be primary care physicians. In our scenario, it has to be a cardiologist, it has to be an anesthesiologist who's expert in obstetrics. And of course, as we go, I'm sure we'll have cardio-obstetric experts in our country also. Then of course, depending upon the kind of disease that lady has, you may have to involve other team members in this cardio-obstetric team. Labor and delivery are again very, very stressful because there are a lot of fluctuations that happen and there could be rapid deterioration, rapid decompensation. Therefore, one has to be very, very watchful during that time. Now, whether to deliver vaginally or to go for a C-section, I think each has its own advantages and disadvantages. And I wouldn't say there is a very definite indication for one over the other, but I think in individual cases, there may be some place for elective cesarean section. And why do I say that? Because emergency cesarean section has a higher mortality as well as morbidity for the mother. So if one is not very comfortable with vaginal delivery, it may be okay to go for planned cesarean section. And these are some of the indications for cesarean section in an elective manner. Severe pulmonary arterial hypertension of whatever cause, acute decompensated heart failure where urgent delivery is warranted, dilated aorta because we are always scared about dissection, or if there is history of dissection already, and it may be, I wouldn't say necessarily, it may be preferred in women who have severe aortic or mitral stenosis, and those who are on anticoagulation with vitamin K antagonists. And this is primarily for those women who have a prosthetic valve and are on warfarin or one of the anticoagulations. The greatest risk, what we have seen also in our practice, is in the first couple of days after delivery, when everybody thinks that things have settled, family is very happy, the woman herself is very happy, but that is the time that they just collapse. And it may be very difficult to resuscitate at that time. In fact, more than 70% of maternal deaths would occur in the postnatal period. And of course, the complications are usual, arrhythmias, heart failure, and so on. So therefore, close monitoring is very, very important, even after delivery in intensive care settings, if possible. Now, let me talk about pulmonary arterial hypertension. Then I'm going to pause before I go to the second lesion. Pulmonary hypertension, I take right in the beginning because the mortality of pulmonary hypertension, maternal mortality of pulmonary hypertension has been really high. In fact, it used to be almost 50% in 1990s, but has now gone down to about 8% or so in highly experienced centers. And of late, there is a large data in 2022 from China where the mortality is less than 1%. But I wouldn't really think that it becomes an indication. I would still say pulmonary hypertension is an absolute contraindication to pregnancy. Survival is much worse in Eisenmenger, where the woman is also a bit cyanosed compared to idiopathic pulmonary artery hypertension. And almost all the deaths occur in the postpartum period within the first week. And I would say within the first 48 hours, most of them would collapse. Even moderate pulmonary hypertension is known to worsen during pregnancy, and therefore there should be regular follow-up of those who are supposed to have mild or even moderate pulmonary arterial hypertension. And of course, worsening of the class, NYHA, high BNP levels, etc., are predictives of serious complications. So how do we manage these women? Aggressive pulmonary vasodilators. In fact, many of our patients who are presenting to us for the first time during pregnancy are on no treatment. But prostacyclin is something that is not really available with us, but one can go for phosphodiesterase inhibitors like sildenafil, tadalafil. And now, of course, Selexipag is also being used in pregnancy, although the data is quite limited. As far as endothelin receptor antagonists, that is ambrisentan, bosentan, and all are concerned, they are actually contraindicated and should not be used. Again, having said that, there are some reports of cases where the women is in a very serious situation, and therefore people have used, because we have to think of the mother over and above the fetus. And of course, prostaglandins, if available, would be required for the class 3 and class 4 patients, especially if the right ventricle is failing. All these women should have anticoagulation in the form of low molecular weight heparin, and of course, treat symptomatically for failure and arrhythmias, etc. And of course, very close monitoring during delivery and in post perpurial period. Planned cesarean section is perhaps the best bet under neuroaxial anesthesia. And again, I would like to invite comments from the obstetric anesthesiologist as well as with obstetricians. Doses of oxytocin should be not in boluses form, but in the form of intravenous infusion. And in rare cases, something that we have never done is use of ECMO in these mothers who are resistant or refractory to conventional therapy. After delivery, same ritual, monitoring very carefully, managing fluid very, very carefully, because if we give too much fluid, they go into failure. If we give too much diuresis, they develop hypotension. Somehow we have to maintain systemic pressure because hypotension in them can be very detrimental. And we often use drugs like milrinone, dobutamine, and levosimendan, which have much less effect on pulmonary vascular resistance. Vasopressin is also a useful drug, and of course, anticoagulation to continue, vasodilators to continue. Now, before I close this particular topic, I just wanted you to see this data, which is from China, published in 2022. And as you would see that as the pulmonary artery pressure rises, which is in green, all the complications increase as expected. And cesarean section has been done in as many as almost 90% in the whole group, which consists of mild, moderate, and severe pulmonary artery hypertension. Mortality 6%, but in Eisenmenger as high as 23%. And of course, we know that offsprings are also at a lot of offspring deaths are expected in these patients. Higher the systolic pulmonary artery pressure, higher the NYHA class, more is the complication expected. Another data from, again, China, much bigger. It's actually multi-centric data where, again, section has been done in 90% of cases. Maternal mortality is about, again, 6%, at least in moderate to severe pulmonary artery hypertension. As you would see, 16 of 19 have died following delivery. Offspring mortality, not too bad, but low birth weight is very common. But what I want to highlight here is that over a period of time, the overall incidence of maternal cardiac outcomes has definitely improved if you look from 1993 till recently. And that is a very encouraging sign, especially for those who have severe pulmonary arterial hypertension. And in the same study, they found that a higher BNP and a higher NYHA class was predictive of worse outcome, whereas a multidisciplinary team as well as strict antenatal supervision was protective for these women. About 30% of these women were on pH-targeted therapy. So I'm going to just stop here if Dr. Paul agrees, and we could have some discussion.
Sure. Thank you, madam. In fact, that was a very clear, lucid lecture. And at this point of time, madam has passed to get the comments from our other experts regarding management of pulmonary hypertension. Madam has highlighted one important point is that we cannot blanket pool together all patients as pulmonary hypertension. And pulmonary hypertension as such, we cannot say that the entire thing is a contraindication as we find in MWHO class 4 of this classification that we are following. Madam has highlighted that patients with severe pulmonary hypertension, mild pulmonary hypertension, moderate, there is always a difference in the outcome. Now, another thing that we had published was an abstract at ACC, the etiology of the pulmonary hypertension. Patients with hyperkinetic pulmonary hypertension, that is without a pulmonary vascular disease setting in ASD or a VSD or a PDA with left to right shunts and pulmonary hypertension, these people, they fared much better than patients with Eisenmenger and primary pulmonary hypertension. So looking at all these things, we need to really work on together. Now, maybe I'll put my question to Dr. Pandya. As an anesthetist, what will be your considerations or what would you like to, when would you like to see this patient? And if the obstetrician and the cardiologist will choose a cesarean section for this delivery, what are your concerns or what are your choices?
Thank you, Dr. Justin, for this wonderful initiative of having these sessions and on master classes. And To begin with, when it comes to pulmonary hypertension, as has been said rightly by Dr. Anita, this is absolute contraindication of pregnancy. But yes, unforeseen reasons, the patient unfortunately comes to us with pregnancy, 14 weeks or more than that, where termination also is not advisable or is equally dangerous. So I'm fortunate enough to work in a center at Fernandez Hospital, a tertiary care perinatal center, where we have an obstetric medicine team and multidisciplinary clinics available in our hospital. So the involvement of anesthesiologist is there right from the pre-pregnancy counseling, if at all the patient comes at that phase. And we insist that if at all the patient misses this way, when we miss to see this patient, we see in at least 4 to 5 times in the antepartum period. Generally, we coincide our PACs with the peaks of cardiac output, like around 16 to 18 weeks, around 28 to 30 weeks, and before term, around 36 weeks, so that bridging therapy, etc., can be appropriately planned. So a proper screening is very important, proper evaluation is very important, and the obstetric medicine team, where we have an obstetric physician, an obstetrician, and anesthesia and critical care, we take care of critical care unit also. We put down our plan at the first visit only, that how are we going to monitor this patient in the first trimester, the second trimester, third important trimester, and importantly, the fourth trimester also, which is considered to be from the time of delivery till 12 weeks of postpartum period. So chalked out plan is laid out. These are, of course, in all in booked cases, antenatal booked cases. So that was what we like to see. And when it comes to the choice of anesthesia, uh, if there is no absolute contraindication for citing a regional, citing an epidural, or neuraxial anesthesia is the best modality. What we have modified over years, because at Fernandez Hospital now we have a series of, you name it, and we have it, all the types of cardiac diseases complicating pregnancy. We give programmed epidural. The siting of epidural at particular levels so that you can minimize the local anesthetic, you can optimize the sympathectomy, you can optimize the hemodynamics. The 5 things which we take care of is PAC R square, the preload, the afterload, the contractility, the rate and rhythm. So whenever we decide about any particular anesthetic technique or any drug that we use in the perioperative or peripartum period, so what is the effect of these anesthetic technique or drug on the preload, the afterload, the contractility, the rate and the rhythm, and we try to maintain as far as possible within the normal range. And we have a low threshold, or rather very low threshold, to put these patients under invasive monitoring, at least the art line. And if possible, in problematic cases, class 3 and class 4 cases, we have a central line also, including cardiac output monitoring devices like Rohtak devices. And again, a usage of ultrasound, so that the fluid administration, everything can be targeted appropriately, so that we can maintain the optimization. Oxytocics, yes, as Dr. Anita rightly said, they are very, very dangerous, very unsafe, and we have had problems using oxytocin rapidly. So you have to be very careful. The fancy oxytocic that has been, I won't say fancy, but the newly introduced oxytocic carbitocin, which is the long-acting, I would resist from using this, because it's a long-acting synthetic oxytocin which acts for a longer time. So slow infusion. The protocol in my hospital is we load 20 units in 20 ml syringe pump and put it at about 3 to 5 ml per hour. 1 ml per hour, 5 units per hour, and continue at least for 2 to 3 hours, depending on that. And if at all a second line drug is required, then depending on the pulmonary hypertension, the SVRs, and other things, we go for either bisoprostol or, and this is where the communication with the obstetrician is very important, because if it's electronic PPH, we can go for mechanical compression sutures, so that you can minimize pharmacological medication. So all these things is very important, goes a long way in planning proper anesthetic care and proper perioperative and postoperative care management. Not to ignore the fourth trimester. That's very, very important. Generally, we tend to ignore the moment the patient delivers. But these patients, Eisenmengers, we have seen, we have lost the patient on 4th post-op day. Because and the patient, so now the policy in our hospital is we transfer the patient, discharge the patient from ICU on the 5th day, especially those with severe pulmonary hypertension.
Thank you, Dr. Pandya. In fact, you made a couple of important points. Thing is, the anesthetist should not be called when the patient is in labor. The anesthetist should be involved in management of these patients much, much earlier, even including pre-conception counseling. That is something that we need to work on in each of our institutions, where we are working on developing a cardio-obstetric team. And
Can I say something? Can
Madam,
I ask? Okay,
yeah,
okay.
please, madam, please, madam. Next is Dr. Sivakumar, and after that, the obstetrician's view, because you are the most important person. You need to respond to any comments given by Dr. Sunil as well as Dr. Shiva. That is why, we are keeping you after them. Next, I request Dr. Sivakumar, his views on managing complex congenital heart diseases, pregnancies and congenital heart diseases, and your comments on what has been discussed.
Thank you, Justin. I think Madam Saxena has nicely described the management strategies. In general, we follow one simple rule. During a pre-conceptional counseling, we classify whether the patient is an acceptable risk Eisenmenger or is it a prohibitive risk Eisenmenger. A prohibitive risk Eisenmenger is one who is defined as those who have severe polycythemia, those who have resting saturations below 85%, those who have elevated proBNP, poor ventricular function, already in heart failure, needing medications beyond pulmonary vasodilators. If they are in prohibitive risk, we strongly counsel them. But still, there will be a small subset of patients who will be adamant on getting pregnant, and their views has to be respected. Then comes the first favorable group, who is acceptable risk group, which means those who are in a very favored hemodynamics, where we expect only minimal changes. In both these patients, if they decide to continue pregnancy, we offer them that we will be providing throughout their entire term a support, both by our entire heart team. Now coming to the medications, Madam clearly pointed out that the drugs that are available in India, which are acceptable, and Selexipag. Sildenafil is used in a dose of 20 milligram 2 times a day, or tadalafil in a dose of 20 milligram once a day. These drugs not only act on pulmonary vascular resistance, but also cause a borderline hypotension. Patients who off right ventricular aggressive sildenafil citrate sometimes may be difficult to continue. And Selexipag is a drug that is quite often not well tolerated due to extremes of prostaglandin related side effects. So in a small proportion of patients who are at an extremely high risk due to an unacceptable hemodynamics, if they are on endothelin receptor antagonist, in our practice, we continue endothelin receptor antagonist also during pregnancy, after fully explaining to the patient, because among the various drugs, namely endothelin receptor antagonist, phosphodiesterase inhibitor, Selexipag, the most tolerated hypotension, and this hypotension results in more difficult.
I think we are losing Dr. Shiva.
Audio is
Audio. Yeah. So Dr. Sivakumar has made an important point that even in a pulmonary hypertension patient, we risk stratify and find out the low risk group and the exorbitant prohibitive high risk groups. And he also shared that some of these centers they use with clear consent the contraindicated drugs also, but we have to understand that bosentan, ambrisentan, all these sentans are contraindicated in pregnancy. So we are not advocating you to use it in pregnancy, but then individuals may choose to do what they are comfortable with, at the same time what they think it is good for the patients with a fully informed consent. But as of now, we don't have enough data. But probably if in case any of you have used them, kindly report. A case report on these things or multiple case reports across the world may help us to tone down the recommendation on these drugs. Now, I request our obstetrician, Dr. Pooja Sikka, to make her comments on managing pulmonary hypertension in pregnancy, and any comments in related to the comments made by Dr. Sunil and Dr. Shiva?
Actually, Dr. Sunil has answered many of our queries, and the comment is from our side, many questions from the obstetricians to the cardiologists. 2-3 things I wanted to ask or tell, that we have pulmonary arterial hypertension as primary pulmonary hypertension and PAH with ASDs and VSDs. Patients who have ASDs, VSDs, and maybe have moderate pulmonary arterial hypertension, are they candidates for drugs like sildenafil during pregnancy? Should they also be given drugs like sildenafil? I am not sure. Some patients in our centers are given these drugs and some patients are not. And when these patients, if these patients are not given, how do we monitor their pulmonary arterial hypertension? And the second query is, many patients come and they ask for admissions, prophylactic admissions at 32 weeks, 28 weeks for oxygen administration. Does supplementation of oxygen in Eisenmenger help? Should it be given? And third thing is, as Dr. Sunil and maybe Dr. Shiva also said, for anticoagulation in patients with pulmonary arterial hypertension, we generally do not give anticoagulation, prophylactic anticoagulation in patients with Eisenmengers, because they generally have thrombocytopenias because of cyanosis. But in postpartum patients, we generally give. And for cesarean versus vaginal delivery, last 6 months, 5 cesareans of Eisenmenger, Dr. Sunil, we have done under TAP block, transverse abdominis plain block. No epidural, no spinal, no GA. So from our side, it is a very high risk pregnancy. They generally are admitted at 32 weeks. They have severe FGRs. They go in for iatrogenic preterm delivery or spontaneous preterm labors. And if they have preeclampsia, they worsen. If they have hypertension during pregnancy, they have a worser prognosis.
I request Dr. Sunil Pandya to answer the last comment, and then I'll request Dr. Anita ma'am to answer the remaining comments and take forward.
The oxygen therapy and drugs with
Last
ASDs.
comment about anesthesia, mode of anesthesia. Maybe you can make the comment, and then I'll request Anita ma'am to go ahead with responding the remaining comments and continue the lecture.
See, what happens is neuraxial anesthesia, I didn't elaborate much, but we program our epidural in such a way that the level of insertion or setting of epidural catheter, of course, it is done by the most experienced person in the team. Unfortunately, we have a cardiac anesthetist in the OB team as well as critical care specialist. So siting of epidural at D2 at L1 and L1, L2 level so that you can minimize the dose of local anesthetic. And as I said, programming means you give small aliquots over a period of 30 to 45 minutes to establish a epidural block. So the sympathectomy induced hemodynamic changes are absolutely, I would say, less than 5%. And of course, we take care of pharmacological drugs like dobutamine and phenylephrine infusion to maintain the SVRs and PVR so that we don't de-optimize or push the patient to the stage of decompensation. And as I said, again, usage of
But how do you monitor for decompensation intra-op on the table?
Invasive monitoring. Because once we establish a baseline arterial trace and an ultrasound-guided fluid assessment, dynamic assessment, of course, I'm going, even if I go back by 1 decade where we didn't have ultrasound in our hospital for the anesthesia department, we used to go just purely by arterial trace. The trace of arterial trace and the interpretation from that trace itself, you can get to know the contractility and many other parameters about the cardiovascular status. And of course, CVP, I know CVP is not a great guide, but definitely if you don't have ultrasound, you can take care of these things. But coming to your bilateral tap black, I must tell you that bilateral tap black in institute like PGI should not be followed. Yes, we know it's a purely sensory block. It does not give any motor block. And you are inducing stress response because of pain and when the muscles are not relaxed, and the stress response can jeopardize the hemodynamics much more. So if you can program the epidural properly, or you can go for a low dose sequential combined spinal epidural, and so that you can minimize the dose of intrathecal component, and subsequently you can slowly volume expand the epidural space. Yes, every technique has certain pitfalls, but as I said, the captain of the ship is very important, and you just have to monitor those 5 things: preload, afterload, contractility, rate, and rhythm. If you can maintain these 5 parameters with pharmacological adjustments and tweaking, you can have a smooth sail. But yes, I must tell you, patients with pulmonary hypertension, they tolerate blood loss very badly. The pulmonary arteries are rigid, they are not reactive, especially when there is a secondary changes in the pulmonary vasculature. So you need to see that the blood replacement and fluid replacement happens dynamically. Otherwise, they tolerate hypovolemia very, very badly. They can instantly have cardiac arrest. We have seen such cases where the patient fall into retonicity. So you just have to be very, very careful about these things. And yes, the patient left lateral tilt and all those things are very important. Yeah.
Thank you. Thank you, sir.
Next, I request Anita ma'am to address any remaining concerns and then go ahead with your lecture, ma'am.
So the first question that Madam asked was about ASD, VSD with moderate pH versus primary pH.
Yes.
Let me make it very clear that if there is a shunt like a VSD or an ASD or even a PDA and the pH is not severe and the lady is not in Eisenmenger syndrome, they are much better than the same pressure in a primary pH. So primary pH, we would be very, very careful. We'll be monitoring, we'll be starting sildenafil or tadalafil even at moderate pH, but in a VSD or PDA, if the pH is moderate, I'm just going to observe because PA pressure is not going to come down with sildenafil or tadalafil because there's a communication between both ventricles or both great arteries. So moderate pulmonary artery hypertension with a shunt lesion and not Eisenmenger is a better lesion than in primary pH for the same level of pulmonary artery pressure. That's number one.
Yes.
Number
Thank
two,
you, ma'am.
about oxygen. I think oxygen is a very potent pulmonary vasodilator. So we do use oxygen in Eisenmenger syndrome whose saturations are low. But if somebody's saturation is already more than 85 or so, I don't find much need for admitting for oxygen therapy unless the woman is symptomatic or she thinks, or if sometimes the saturation goes down when they work or when they exert. So it may be a good resting saturation, but on exertion it may fall to below 80 or 85. And then oxygen might help. So I think it's a good pulmonary vasodilator, and in situations where hypoxia is high or on exertion, we should think about giving long, 8 or 9 hours of oxygen therapy to these women, and obviously that can be done after admitting them. Regarding your third question about anticoagulation, in pulmonary artery hypertension, there's a recommendation for giving low molecular weight heparin as a prophylactic measure. Surely, if there is any evidence of coagulation disorder, then you wouldn't be very comfortable giving them low molecular weight heparin, or if there is thrombocytopenia, also you wouldn't like to maybe venture into it. But if there is any ventricular dysfunction, if there is any arrhythmia, if there is any history of thromboembolism, I think we should not withhold anticoagulation. We should give it. Yes, you obviously have, you're kind of walking a very tight rope both ways, especially when the woman goes into labor and there is chances of postpartum hemorrhage, then you may be worried. But I think during pregnancy, we should try and give as much as possible to all these women.
You can continue the lecture now. Thank
All
you.
right. So I think I'm going to now move on to a little different topic, again, congenital heart only. And that is on severe aortic stenosis, another congenital heart disease. And here I have specifically written severe aortic stenosis because usually mild and moderate aortic stenosis do not give much trouble during pregnancy, and we wouldn't tell these women not to get pregnant. But yes, severe valvular aortic stenosis, especially if patient is symptomatic, is an absolute no contraindication to pregnancy. And again, this data is from Rohtak, where they had 34 cases of severe aortic stenosis out of 2,966 pregnancies. Heart failure can occur in about 1/4 to 1/3 of these women who are having severe symptomatic aortic stenosis, but most can be managed with medical therapy, with low-dose diuretics, bed rest, and so on. And only occasionally one may have to go ahead with aortic valve balloon dilatation. So this is a little different from severe mitral stenosis, which really tends to be very aggressive and tends to require some therapy during the second trimester. AS in severe AS, we can probably sit tight and see if we want to go ahead and do it or not. I only remember one case that we had to do in a pregnant woman because of her being very symptomatic, not settling with the usual therapy. Again, cesarean section is a better choice for severe symptomatic aortic stenosis. And as far as fetus is concerned, we do expect high incidence of prematurity and small for gestational age. So this is something that is expected. But as I said, it is mother, which is far more important than the baby. Another aortic disease is aortic coarctation. Fortunately, most of these coarctations do well unless their blood pressure is uncontrolled. We need to give them lots of drugs to keep their blood pressure under control. But another fear that we have is that of dissection, because many of them would have aortopathy. And again, unless we are forced to, we wouldn't like to intervene during pregnancy. But yes, there are a couple of reports. These are 4 cases from Kyiv, Ukraine, where they did balloon dilatation during pregnancy between 15 and 23 weeks of pregnancy in those who had dilated aorta with severe hypertension secondary to coarctation of aorta. But in majority of cases, we manage with close monitoring, especially for the aortic size and the blood pressure. Aortopathy is a bit of a dangerous situation, and this can happen with bicuspid aortic valve, or it could be one of those hereditary disorder of thoracic aorta. There is definite risk of dissection, although it is low. But the trouble is that if dissection happens, then the mortality is extremely high. And therefore, these women must be kept in close observation with serial imaging for size. They should be on beta blockers, and of course they should deliver at a center where cardiothoracic surgery is immediately available in case dissection happens. So this is, although rare, but is often fatal if dissection happens. So that is really the importance of this disease. So I'm just going to finish with the cyanotic heart disease, which is classical tetralogy is what I'm going to talk about. Again, I didn't see much data in the literature as far as tetralogy goes, because majority of these would have been repaired. But what happens in tetralogy is, because of a fall in systemic vascular resistance, one expects worsening of cyanosis and hypoxia in these women. And that may obviously result in many other complications, including complications to the fetus. And maternal complications include right ventricular failure, worsening of cyanosis, hypoxia, dyspnea, and so on. A lot of fetal growth retardation. In fact, I think fetal vestage is perhaps highest in cyanotic heart diseases, where spontaneous abortion is quite common. And in one of the studies published a long time ago, it said that if the saturation is less than 85%, then the live births are as low as 12%. So this is something I think we need to counsel the lady, that the likelihood of fetal vestage is going to be very high, even if she continues to do well. Then of course there is worry about postpartum bleeding complications, because these women have coagulation abnormalities as an inherent part of cyanosis. So we must treat iron deficiency in them. We know that hemoglobin may be, 10 may be taken as normal, but in tetralogies, we would want it to be more than 14. They should limit their activities. Again, there should be serial monitoring, not just of saturation, but also ventricular function by NT-proBNP or a BNP. And this has been shown to be quite useful in these women. Good hydration is again very, very important. At all points of time, they need to be well hydrated. And again, vaginal is perhaps the best mode of delivery for them. Cesarean section only for obstetric indications. Again, avoid hypoxia, avoid respiratory acidosis, avoid hypothermia, keep them warm, keep them well hydrated, maybe give them oxygen if required, although saturation may not improve much with oxygen. They all need antibiotic prophylaxis against bacterial endocarditis, and again, very careful monitoring during delivery and postpartum period due to sudden cardiovascular alteration. Any situation or any drug which causes reduction in the blood pressure, reduction in the systemic vascular resistance, is going to increase the right to left shunting and is going to worsen hypoxia. So one has to avoid that. This is just the, one of the studies that I came across where it is clearly seen that the fetal weight is very low. There is prematurity in this study, and maternal outcomes are also showing a lot of complications, almost 32%. But the good news is that over a period of time, this seems to have come down to some extent with, again, perhaps a team approach or a cardio-obstetric team approach. So this is just to, give a bit of a encouragement to all of us that over a period of time, if we look at the data of PREG1 and PREG2, again published in the Rohtak registry, you would see that the number of women in whom the pregnancy would have been contraindicated has gone up from 0.5% in Preg 1 to 9.1% in Preg 2. And the reason being that the data is collected a lot more from emerging economies than it used to be in the Preg 1 cohort. So we have much more representation of countries like India, where in Preg 2 than in Preg 1. And that may be the reason why we have more class 4 or risk class 4 women. But what is heartening to know is that maternal mortality, fetal mortality, morbidity, heart failure, neonatal mortality hasn't gone up. So that, I believe, is a sign of success, that we are doing well despite the fact that we have more mothers who are now in high risk category. And same data I'm just going to show you here, that green is emerging countries and blue is the developed countries. And again, you would see that it is in green that the death or heart failure has really gone down over a period of time. So I think we are getting better and better. But again, I think where pregnancy is contraindicated, it is contraindicated still. So pregnancy is a major life event, but a lot of women will either risk their own health, or some of the women are not even aware that they have a congenital heart disease and they come already pregnant. Yes, maternal and fetal outcomes have improved significantly even in class 4, but I don't want to give a message that one can go for pregnancy in these conditions. It is still a contraindication. But if these women decide to continue pregnancy, then we have to be extremely careful, have a team approach. And I think all of us, obstetricians, anesthesiologists, everybody really has to start with understanding of the underlying CHD and its hemodynamic changes and its effect on the hemodynamic changes due to pregnancy or during pregnancy. And of course, a close vigilance throughout pregnancy, labor, and postpartum period would be very important for a successful maternal as well as a fetal outcome. Thank you very much. I'm going to stop here. Thank you.
Thank you, ma'am. In fact, you had touched upon two or three other important areas where pregnancy is considered a very high risk. Patients with outflow tract obstructions, like aortic valve stenosis, or coarctation of aorta and aortopathies, how we have to handle them. The other area touched upon is severe cyanosis and cyanotic heart diseases, primarily diseases of hypoxemia and cyanosis. Now, I'll open this to the comments from the panelists, from three specialists, and we also have some questions in the chat box, in the Q&A section. Some of them have been already answered by Dr. Sivakumar, and some of them have been answered live. As I invite the panelists, I also request them to look at the questions there, and in case anything is related to their specialty, I request you to address them as and when it comes. And maybe I request Dr. Sivakumar to give your views on, you can touch upon the first question as well, managing unrepaired pulmonary atresia and severe cyanosis, and any comments related to cyanotic heart diseases and how you handle them. Shiva, it's yours.
Yeah, it is quite interesting that Madam Saxena decided to add this fourth last group of uncorrected tetralogy of Fallot, which by and large was not considered as a major disease of significance in the West, in view of the rarity of such diseases going on to adulthood with persistent cyanosis, while the truth is in India, in many centers, these patients continue to be uncorrected. Having said that, since our states in the southern part of the country, such as Tamil Nadu and Kerala, have got far better medical facilities, we would rather say there are only three groups of patients who get into this syndrome. One is tetralogy of Fallot with extremely hypoplastic pulmonary arteries or single pulmonary artery. The second is tetralogy of Fallot with multiple epicollaterals that were never amenable for any form of surgical correction. The third one is partially corrected univentricular hearts, which means bidirectional Glenn has been done. They were not candidates for a completion of Fontan. And when only the upper half of the body venous drainage drains into the pulmonary circulation, the lower half of the body continues to drain into the heart. With progressive pregnancy, more and more of the maternal cardiac output is actually directed towards the lower half of the body, causing progressive desaturation as the pregnancy progresses. And this particular group tends to go progressively more and more hypoxic. Fortunately, there may be a small number of patients who are actually uncorrected univentricular hearts, such as patients who have univentricular heart who had presented little older so that they were not considered to be candidates for a Glenn or a Fontan, but they continue to remain cyanotic. Our strategies were, number one, if the patient was an uncorrected tetralogy of Fallot or a patient with a univentricular heart with an antegrade pulmonary blood flow, we try to promote their pulmonary blood flow by either a balloon angioplasty or sometimes even stent angioplasty of the right ventricular or subpulmonary outflow tract of some of these patients in order to promote a little higher saturation. Of course, this procedure will be done with a graded pulmonary artery pressure monitoring. That means for every 2 millimeter increase in the balloon or stent diameter, we will check the pulmonary artery pressure, ensure that we are not overflooding the lungs. This is the pre-pregnancy strategy. If suppose they present during the time of pregnancy, many of these hypoxic patients may get a marginal improvement by home oxygen, which means sometimes they may be even put on home oxygen for 24 hours in a day, because this may promote, even if there is a 5% step up in the amount of systemic saturation, this will improve the fetal growth and ultimately make the neonatologist work far better and make the child much more possible to live in the society. And of course, as madam said, good rest, lot of fluids, ensure that they don't get into complications of polycythemia are extremely vital. Then comes the last problem of these hypoxic patients going into labor. A very careful management by the obstetrician as well as the anesthetist. I'm sure the team experts in this field will tell. In fact, as I speak to you, yesterday we had a tetralogy of Fallot who was having only 70% saturation with multiple epicollaterals, which are very, very small, who successfully delivered a 1.2 kilogram baby after all the pain and efforts that we put in by giving home oxygen and continuously close monitoring. We have to understand that these patients tend to be severely growth restricted. However, a desirous mother may still be able to complete her successful pregnancy.
Thank you, Shiva, and I will request Dr. Pandya to give his comments on anesthetist.
Yeah, when it comes to this bicuspid aortic valve, aortic stenosis, or any Fallot tetralogy coming in for normal delivery, again, I would suggest that these patients are seen thoroughly by the anesthesiologist, and especially with aortic stenosis, if they come pre-pregnancy counseling, of course, we always rely more on pre-pregnancy transvalvular gradients rather than during pregnancy, because all the gradients are increased during pregnancy. So risk stratification pre-pregnancy is very, very important. And of course, when it comes to management of labor in these patients, we encourage as a modality, epidural analgesia as a modality of choice, and it's therapeutic in nature, provided there is no contraindication. And I must tell you that even small little things during intrapartum period and peripartum period matter. I still vividly remember one patient of Fallot tetralogy, SATs of around 75%, had a normal delivery, mild atonic PPH, which was controlled with oxytocin and bimanual massage. And subsequently, about 10 minutes later, the patient arrested. And when we looked at the sequence of events, yes, she was relatively hypovolemic, but importantly, the lithotomy was the way when the patient was straightened the legs from lithotomy to supine position, she arrested. That means even the when you're changing the position from lithotomy to supine or supine to lithotomy, you need to remember the hemodynamic implications. Even those mild sympatholysis, mild blood loss, mild SVR changes related to oxytocin, and change of position from lithotomy to supine, everything has to be meticulously done, meticulously planned, and you cannot take things for granted. So involvement of team as a whole is very, very important. And as like when you have a baby of 1.2 kgs or a very low birth with a low birth with babies, they directly take the babies to an ICU, and the baby may require surfactant or CPAP or any of those things. But it is very prudent on the part of an obstetric intensivist anesthetist to see that the metal bonding is established, so that the skin-to-skin contact and metal bonding via telephonic or via video, or if the mother can go to labor room, so that the lactation failure rate can be minimized. So all these things matter much. I didn't discuss much about general anesthesia in these patients. Yes, there's a small chunk of women where regional is absolute contraindicated when the patient comes in an emergency and there is a patient is on full dose anticoagulants. Yes, we go for general. It is believe me, it is not, it is quite safe. The only thing is you need to make sure that what is the influence of whatever anesthetic drugs you're going to give on those 5 parameters which I have emphasized earlier: preload, afterload, contractility, rate and rhythm. So try to give medications like opioid-based anesthesia, informing your neonatologist that you may have to give naloxone to the baby in case if the neonate is apneic. So this communication within the team is very important. And generally, narcotic-based anesthesia with sevoflurane or desflurane, suppressing the laryngosympathetic response during intubation and during extubation. And as Dr. Anita rightly said, minimizing hypoxemia and hypercarbia, because of even transient and desaturation that you see during intubation should not happen. So now we have HFNCs and perioxygen. Several techniques are there. I don't want to go into the details, but minimize hypoxemia, hypercarbia, hypothermia during all these things, and titrated fluids and oxytocics, and good nerve blocks like TAP block for post-op analgesia or intrathecal morphine for prolonged blockage. All these things matter the most. And not to forget the fourth trimester monitoring. You need to have a proper plan for first 72 hours. I must tell you that pregnancy is a low oncotic pressure state. The colon oncotic pressures are low, and the peak reduction in colon oncotic pressure happens between 48 to 72 hours. So majority of the patients, they are stable in first 24 to 48 hours, but they decompensate on the third and the fourth day, or second and the third day. So prolonged monitoring of these patients is of vital importance, so that even that destabilization period, you can optimize it immediately and promptly. And post-delivery, the increase in cardiac output, the fourth peak which happens because the uterine contractions have to be taken care of, and you need to offload this by diuretics at this phase. So all these things matter most when you're managing high risk cardiac parturiate. And one more, sorry sir, last thing, anticoagulation. Post-operative, we have seen patients when you are giving LNWH as a prophylaxis for 5 days or 1 week doesn't suffice. In patients who are polycythemics, in patients who are cyanotics, and patients who are NT-proBNP levels are high, postpartum thromboprophylaxis should continue for at least 4 to 6 weeks. We have had cases where the patient developed pulmonary embolism in the second week and the third week, and they came back with desaturation. So when we looked at the data, yes, the 5 days or 6 days of prophylaxis will not work. You need to give at least for 4 to 6 weeks.
Thank you, Dr. Sunil. Now I invite Dr. Pooja. You can make your comments along with the answering 1 or 2 questions relevant to your session in the panel.
Some additions from my side. Generally, these patients deliver at around 37 weeks because of the cyanosis, but we should consider a planned delivery. They should deliver during a daytime. A senior obstetrician should always be involved in their delivery. Always tell the neonatologist that such a baby and such a mother is going to deliver. You should go in for strict fetal maternal monitoring. Strict pain relief may be a relief if a relative stands by her during labor. Keep blood arranged for such patients, because if they have PPH, she requires blood. The best resuscitation in a cyanotic heart disease is blood for managing her dehydration and her hypoxia. Send her ABG, keep her electrolytes, get a PAC done, inform your anesthesia team till she delivers. And after her delivery, even if it is a normal vaginal delivery, shift her to HDU.
What is your
And one thing we did not discuss is that the patients, the mothers with congenital heart disease, the issue of the baby having a congenital heart disease should always be discussed, and a fetal echo between 18 to 22 weeks in mothers with congenital heart disease should be mandatory.
Thank you, Dr. Pooja. Would you like to comment on the oxytocin and pulmonary hypertension, because it's known that oxytocin can increase the pulmonary vascular risk?
Yes.
What will be your choice of inducing?
The basic, we have generally 3-4 oxytocics in our labor room: oxytocin, methergin, carboprost, that is prostaglandins, and these 3, misoprostol. So the ideal oxytocic for any PPH or for prophylaxis of PPH in any cardiac disease is oxytocin at a controlled rate. Excess of oxytocin leads to vasodilatation and it can worsen the cyanosis. But the other drugs like methergin, carboprost, prostaglandin F2 alpha leads to severe pulmonary vasoconstriction, leads to it worsens, it increases the pulmonary hypertension. So it is completely contraindicated. Methargin is completely contraindicated. The second drug, if the patient has PPH with blood, we should consider misoprostol, PGE1.
Thank you, Dr. Pooja. I think
Consider oxytocin only, with Bakri balloon, with blood, with fluids.
I think we have come to towards the end of this program, and our panelists have given clear answers and many. And I request all of you to look at the Q&A chat in the chat box. Many Dr. Shiva and many other panelists are answering live. Please look at that. Anita ma'am, Saxena ma'am, you would like to make any comments on what has been discussed so far?
I think my last comment that I wanted to make is already made by Dr. Pooja, that we shouldn't forget about the baby. It's, in fact, the mother is taking all this trouble for having a baby. So although I did mention briefly in my general kind of slides that a fetal assessment at the right time for fetal anatomy is very, very important. And therefore, at the end of the day, since we know that the likelihood of CHD is higher in these babies compared to normal pregnancies, especially those who have left ventricular outflow tract obstructions, the likelihood of a baby having exactly the same disease is quite high. And therefore, it is also important to have the well-being of the baby in terms of any structural heart disease or any congenital disease, not only heart, congenital disease. So I think a very thorough evaluation or anomaly scan is something that must be done for these babies, because, as I said, the mother is going to be very happy when the baby is healthy, not otherwise.
Thank you, madam. I would like to inform all the participants who are attendees. We would like to tell you that those of us who are here, we don't consider ourselves as experts. Many of you sitting as attendees today are experts. All of us are learning and sharing our experiences. In fact, we are increasing our faculty size. So if any of you are willing to be a part of this program, would like to share your case, you would like to have a case presentation, or you would like to discuss something, or you would like to give lectures, please message us, number one. And number two is that, we next month, that is February, the first Friday, we'll be presenting a case on prosthetic valve in pregnancy, and we'll be having a discussion on prosthetic valve in pregnancy. So please mark your dates. It's 2nd of February, Friday, 8 to 9. And subsequently, the topics that we are having in mind, the cases are, some of the institutions are ready with their cases already, a Fontan in pregnancy, and then a case presentation of Fontan in pregnancy, followed by managing complex Fontans and uncomplicated Fontans. And we also have a case presentation on pulmonary hypertension in pregnancy and a discussion on pulmonary hypertension in pregnancy. We have a session ready on contraception in women with heart disease. So there are programs already in the pipeline. So next month I have already announced, and please do stick with us and guide us. It is, it is a noble venture. I'm so happy and thankful to all of you for having come here, but not just as visitors or attendees alone, but also as faculties and panelists. And we have shared the group, those who are, where you can express your desire and your field of interest. Please do fill it and partake in it. Over to you, Annie.
Thank you, sir. So I thank the speaker and all the panelists for such a lively discussion. I now request Dr. Shakuntyagi ma'am to propose a vote of thanks.
Thank you, Annie. Am I audible?
Very
Yes,
much.
ma'am.
Yeah. Thank you, Professor Justin, for organizing this cardio-obstetric class. It was wonderful. And I would also like to extend my heartfelt gratitude to all the attendees. We had an attendance of almost 200 at the peak. It was very well attended. And thank you so much, Professor Anita Saxena, for your lucid presentation. It was wonderful. It was really nice to hear from such an eminent speaker, so nicely explained. It was first time, it was actually like going to class again. So, and thank you, the panelists, Dr. Pooja, Dr. Sivakumar, Dr. Sunil, Pandya, for their very insightful contribution, and it was a very enriching discussion. And thank you for all organizing it so nicely. Let's meet next time again, first Friday of next month. Thank you, Professor Justin. Thank you.
Thank you all. Thank you.
So I thank everyone for being a part of this wonderful initiative packed with passion towards this field, cardio-obstetrics. So until we meet next time, have a great month. Thank you.
Thank you. Thank you.